All right, today I am joined again with Dr. Natalie Scheeler, one of the newest members of Modern Med. Welcome, Dr. Natalie.
Thank you. Excited to be here.
Yeah, and this is kind of a continuation of the last recording we did, which was on inflammatory bowel disease, ulcerative colitis, Crohn's disease. And we wanted to make this a separate video because there's so much to unpack with fecal microbiota transplantation, FMT. So we have this as a separate video, but please refer back to the IBD video because if you are looking, for information about ulcerative colitis or Crohn's, we put a lot of information in there. How you doing today though? How's everything going?
I'm doing well. Got some nice weather here, so enjoying that. How about
Good.
yourself?
Awesome. Same. It's beautiful out.
Yeah.
Yeah, absolutely. So I'm excited to dive into this with you. We were talking before, and I was like, I want to make this just a conversation between, you and me, like a peer-to-peer consult, because you are more knowledgeable about FMT than I am. You've had more experience with it. You've treated more patients with IBD, and I'm always looking to learn. And so that's kind of how we're going to frame this whole conversation: is me picking your brain about all the things that I selfishly want to learn about, and then hopefully others are going to be learning as well through that
Yeah.
lens. But
Awesome.
first, before we go like too in depth, like what is FMT? Like what even is it? What does it stand for? And then we'll go in from there.
So FMT, as you said, it stands for Fecal Microbiota Transplant. And what that looks like is we take donor from a healthy person, we take stool from a healthy donor, we transplant that into um, another person with the goal of bringing in healthy microbes into that recipient's gut.
Yeah. Yeah. So it's the same as like a blood transfusion, or, it's the same as an organ transplant too, in terms of like the idea behind it, where you have somebody who's sick, somebody who's healthy, and you're taking the healthy person's stool and implanting it into the sick person's um, GI tract in the hopes of getting them better.
Yeah,
Um,
absolutely.
and we obviously don't do this for every disease, but like what are the ones that are, what are the ones that make sense and have research behind them where we would use FMT to actually treat them?
Yeah, so right now the FDA only approves FMT for treatment-resistant C. diff. So that's the most common that we see FMT used for, but there's also research to support it for the use of inflammatory bowel disease, which is a lot of what we do at Modern Med. There is some research, and we can get into it with IBS and SIBO as well, but those are the main ones there.
Yeah, and for those who don't know, C. diff is an infection of the intestinal tract. It results in pseudomembranous colitis. Um, what else do you have to say about that one? It could be life-threatening, especially in elderly patients.
Yeah, absolutely. We typically think about that as after developing it after antibiotic use or after a stay in a hospital is the classic. And there's a specific odor to C. diff
Hmm,
infection that many people, they've had a C. diff infection, are very familiar with and recognizable.
yeah. How do you describe the odor?
Bad. It's a really strong foul odor.
Yeah,
Hmm.
interesting.
Hmm.
And diarrhea is common with C. diff as
Yes.
well.
Yeah. Yeah.
Like really bad watery diarrhea.
Hmm. Hmm.
Okay, and then how did FMT come to be here? What's the history of it? Because it's much longer than I think a lot of people would think.
Yeah, so the first use, documented use of FMT was in the fourth century. So a very long time ago in China by a Chinese physician, and he used it for people who had diarrhea. He would take healthy donor stool. In this case, he would take that stool and he would make a broth out of it, and it was taken orally. So there's a little bit of a joke that it did not last because not a lot of people like poo stew, and that's
Mhm.
essentially what it was. So that was the first documented use, and then we do see it throughout history again with veterinary medicine, farming. A lot of cattle would be given stool from other cattle if they had any metabolic or gastrointestinal diseases. And then in the more recent history, in about 1950s, there was a study done where pseudomembranous colitis, which we talked about with C. diff infection above, was treated in 4 patients with FMT and successfully. And at that point, we did not know it was C. diff because it was not
Mhm.
connected until the 1970s. But When that study was completed and we saw benefit, that pushed for more studies in FMT. And then in the early 2000s, about the turn of the century, a new C. diff strain came about that was rampant and more intense. And so that pushed more research on both FMT and the microbiome. And then most recent, in about 2013, the FDA said that they were going to start to regulate FMT as an investigational new drug. And then in November of this past year, 2022, the first FMT product called Rebiota was approved, and that is a rectal suspension form. And then in April of this year, Voust, which is an oral capsule FMT product, was approved for both of those, as we said above, for that prevention of treatment-resistant C. diff.
Yeah, I love that you just covered from the 4th century to 2023 in like 4
Yeah.
minutes, which is awesome. The name of the broth, you said it right, was like yellow soup is what they called it. I think that's so
Hmm.
fascinating. The other thing I
Yeah.
think is really interesting, and I don't know if you've thought about this. I know nothing about veterinary medicine, so this is me just being a lay person when I discuss this, but um, dogs will eat other dogs' poop. And I
Hmm.
always wonder, I'm like, I feel like there's something to that where maybe they're trying to get something or like treat themselves. But maybe not. Maybe it's just like a thing that animals do. But I think it's pretty common in a lot of animals, right?
Yeah, it is. I actually was looking into this recently. I think so. There's a little bit of an unknown, and is that are they trying to get beneficial? And then I guess too, some animal digestive tracts do better if they digest fiber twice. And so eating the fiber out of this stool of
Oh,
another animal can be helpful too. But
interesting. Yeah, and
yeah,
there's a name for it too. It's like chorophagia or something like that, where
yeah,
yeah, I don't know. I mean,
sounds familiar, but I'm not
we're getting into
up to
vet
date.
medicine outside of
Yeah.
our scope.
Yeah.
But yeah, just really interesting that there's, this exists in other species in a very different way, which we would not recommend for humans for many reasons, but interesting to talk about nonetheless.
Yeah, for sure.
Um, so let's go into like first, you said C. diff right now is the only condition that's approved to be treated with FMT in the United States. So let's
Hmm.
just talk about like what does that mean then? Like, can people with ulcerative colitis or Crohn's get FMT, or how does this whole thing work from a legal standpoint as well?
Yeah, yeah. So unfortunately, that designation makes it difficult to get it if you do not have that treatment-resistant C. diff. And those who do treatment-resistant C. diff means that somebody has a C. diff infection, treated it with an antibiotic that is warranted, either vancomycin or difficid, and did not respond and did not clear the infection. Um, so that's what can get you access to those stool banks and be able to use these products that the FDA has approved. You do not fit that category, which unfortunately is most of the patients that we see. That means that you're not able to receive stool from a donor stool bank that is regulated and or use Rebiota or Voust approved by under an approved designation. Um, what ends up happening is typically people will do FMT if they're interested in doing it with these conditions at home, finding a donor on their own. And what we do at Modern Med is help people find a donor, screen the donor so that they can do it safely, and then help them through the steps of what that looks like at home so it can be done in a safe manner.
Yeah, yeah. Yeah, and I view this as harm reduction. So it's one of the things that I'm passionate about, harm reduction. I have a huge passion in terms of harm reduction from overdoses as well, but this is just a
Mhm.
different category of harm reduction where people have been doing FMT at home for IBD for very like a lot of years, and when it goes unregulated, there becomes safety concerns where if you're going to do this, you could possibly get an infection or something more serious. And so our view at Modern Med is that we want to make this the safest avenue possible for people. And
Mhm.
we would rather provide a service of screening their donors versus have them do it on their own and not screen any of their donors, which is, makes sense to me. It's like giving a teenager a condom versus telling them not to have sex. I think
Yeah.
we can kind of view it in that point. It makes sense.
Yeah,
Um,
absolutely.
so let's go into, we talked about C. diff, but what about ulcerative colitis. Let's talk about that one first with the use of FMT, because it's probably one of the most common things we see in our practice that come in with the at least the curiosity
Mhm.
about FMT.
Yeah, yeah. So there are about four major studies that we look at for benefit in about 2015 to 2017. And from those four studies, we see about a 25 to 35% of those who received that FMT intervention compared to the placebo group had reached remission. And so that's both clinical, which would be symptom remission, and endoscopic remission, which means not seeing any form of disease on colonoscopy. So that's huge. That's really big. That's the goal. We want to reach endoscopic remission, histologic remission. And so very, very positive there. Um, yeah, so 25 to 35% benefit compared to about 8 to 10% of that reaching remission in placebo groups with FMT and ulcerative colitis. There is a little bit of a range of how that FMT is done. So in some of the studies, they use a single donor versus a multi-donor. So one person donating that stool versus the blend of a few donor mix. And then how they deliver that deliver that stool, donor stool is different. So they can do it through a colonoscope. So in colonoscopy, enema was done as well as endoscopy or nasoduodenal tube going through the nose and going into the small intestine or going through the mouth into the small intestine and delivering it there. So mixed there. When we talk about doing it at home for a UC, we obviously don't have access to a colonoscope or endoscopy, but that's okay. With the enema, we see that the benefit is still within that range, and enemas are really safe and easy to use at home if done correctly.
Yeah, okay. And in the studies you're referencing, what was the basic protocol? I don't mean specifics, but in terms of how many, was this a single FMT installation where they just did it one single day, or did they do multiple days of FMT?
Yeah, it is mixed. So some were single day, one time through colonoscope. Some were one study was when they did it through colonoscopy, and then they had them do two enemas in the weeks following. And then some were more frequent. And we can talk about it a little bit more further on too, but typically what we've taken from the research, which I've taken for the research, is about for those with IBD, colonic IBD in general, would I find best about 10 treatments consecutively or semi-consecutively, so over a 10, 14-day period seems to be where we get the best outcomes, but that can vary and be individualized too.
Yeah, okay. So really interesting they're getting such great results with just one. Like that's surprising to me.
Mhm.
And so you said about like it was about 25% versus the placebo group was around 10%. So you're getting an additional 15, is that right?
Yeah, 25 to 35, 8 to 10.
35. Okay, got it.
Mhm,
And
mhm.
what are they comparing the FMT group to? Like what are the placebos? I'm guessing they're receiving some treatment, of course.
Yeah, typically that placebo is what we call autologous stool. So they'll take the stool from the person and then re-implant it from whichever form that they were, whichever delivery method they were using. So no real change that we expect from the microbiome, but you still go through the same process.
Yep.
Um,
Yep.
mhm.
And when you have these two groups, were they also on like mesalamine? Like, was there a baseline treatment that they were, both going through at the time?
Yeah, so generally speaking, with these studies, we do have patients on other medications because it's not great to take people off medications. But that is things that they looked at in some of the studies is were you able to reduce your medications, come off certain medications? Typically speaking, in the research realm of FMT, they like to avoid patients being on biologics. And so a lot of the studies will be on patients who are either on mesalamine or steroids or
Yep.
um, yeah,
Yep.
non-biologic drugs.
And any studies that have shown FMT versus a biologic, first of all, just to describe what a biologic is, just really briefly, so people know, and maybe some examples too.
Yeah, so biologics are drugs that are developed from human-like tissue, and they are one of the common drugs that are used for autoimmune disease, including inflammatory bowel disease. So things like Stelara, Humira, all biologics, the common biologics that are used. Um, and repeat your first part of that question.
Yeah, I was just saying, are there any studies that show, FMT is this effective to be putting people into remission versus a biologic? Like,
Yeah.
is this apples to oranges, or can we make some comparison there?
Yeah, so I am not aware of any direct studies between biologics and FMT. But if we look at biologic improvements, we typically see that number around 15%. So it is similar if you're looking at that 8 to 10 versus 25 to 35%. However, biologics do come out with risk factors that can be pretty significant. And there is also a cost associated with biologics. They're a long-term therapy and they have can have a large financial cost too.
Yeah. Okay. Um, and then what about Crohn's disease? So, we have a video, so I want to refer people back to that. But there's a big difference between Crohn's and colitis in terms of location, which I feel like is important when
Mhm,
we talk about FMT.
mhm.
First, can you just talk about the difference in that location with Crohn's and UC, and then, let's get into the FMT stuff around Crohn's
Yeah,
disease.
yeah. So ulcerative colitis, we typically see, or we do see that inflammation in the colon. Crohn's disease, that inflammation can be anywhere in the digestive tract. The most common place for that to be is the end of the small intestine. I do see, and from my experience with FMT, is those people with Crohn's who have the inflammation at the end of the small intestine or in that colon, which where it can be as well. We do have the best effect with FMT, especially when we're doing it via enema because we're in the colon. That's where we're kind of modulating that microbiome. Um, but there is a difference there. Can be anywhere along that tract. Um, and so with that too, a lot of the research with Crohn's disease is on Crohn's disease that is located in the colon. But there is a lot of benefit that we do see. I think so in the research, about 57 in a recent meta-analysis, they found that 57% of patients, adult patients with Crohn's disease, who um, completed FMT had clinical remission at the end of 2 to 4 weeks, which is very significant. The one asterisk here is that they did not see endoscopic change. So you, through endoscopy, looking at the small intestine, upper part of small intestine, you don't see ileum, that end of the small intestine through endoscopy. Um, they did not see change at the end of 4, 8, or 12 weeks, depending on when they looked on the patient population. But as far as benefit, we do see it symptom-wise, inflammation-wise, and so can definitely still be a really good option for those with Crohn's disease.
Yeah. Um, how many times did they do FMT in that study? Do you remember? I know it's a specific
So
detail.
that was a study that was looking at like almost 10 studies.
That was okay.
So it was a varied of how they did it. And again, it was similar to the UC that you can location, et cetera, delivery
Yeah.
method, number of
Yeah.
donors. And I mean, as far as kind of what I see is if there is inflammation in the colon with that Crohn's disease, we have similar benefit as you see. And typically ish those numbers look like 75% will have 50 to 75% will have a positive response um, in some sort, whether it's symptoms, inflammation, and reduction in inflammation numbers, or or about like a third to a half can reach clinical remission, which is pretty significant, and that includes histologic remission too.
Yeah, that's really significant. I
Hmm.
mean, this just really shows how important it is that we do more research too, because it feels like we're on to something.
Hmm.
And with Crohn's, the active disease is deeper in the tissue. So I just wonder, like, do they have to do longer course of treatment,
Hmm.
more of them, to then end up seeing the endoscopic remission as well as the clinical? Like, are we starting to see it, but it's just not enough, not long enough, or what is it? Yeah.
Yeah. And that's a good point too. The 10 treatments that I typically start with is more than that is done in research. That is higher than we see in those numbers, but it's what we found to be the
Yeah.
most expected, I mean, most effective, long-lasting, durable
Yeah.
improvement.
Okay. And we're gonna go into more about like what does this look like, the protocol in a little bit, but I just want to
Mhm,
stay in terms of the different conditions. And so I want to move
mhm,
on because we get this all the time where people do complimentary calls with us and they ask about, I have constipation or I have IBS or I have
mhm.
SIBO. I want to do FMT. It
Hmm.
kind of feels to me when I talk to people is like it's the Hail Mary, right? And it's like I have tried everything else. I don't know what to do. Can this help me?
Hmm.
Um, any research when it comes to any of these more like functional bowel disorders?
Yeah, so there's some research on IBS. There's three major studies that were placebo double blind. The one did not show any benefit, and that was done with oral capsules. And then two showed positive benefit, both of which or one was done via endoscopic delivery into the small intestine, one via colonoscope into the colon, and both showed pretty significant improvements in symptoms compared to placebo. I think as far as what I've seen in practice too, with people coming to IBS, it is a little bit of a Hail Mary. It's not my first go-to. It's when we've kind of exhausted some of the other options. Um, and we can definitely see benefit. It's not with those same positive numbers that we see with IBD, but um, definitely possible. The other thing I think about too is that in the functional bowel disorders, everything kind of gets clumped as IBS, even though sometimes functionally we have some differentiators and we think about different forms of treatment. Um, so they're all getting the same FMT treatment of however frequency, et cetera, when maybe it would make sense to tailor it to the individual a little bit more in those studies. And so that can maybe account for the mixed response or um, there.
Yeah,
And then
and so
SIBO too. Oh, sorry.
no, it's okay. So
And
you're saying that they are they're doing these studies on IBS in general. They're not pulling out IBS-C, constipation predominant, IBS-D, IBS-M. Yeah.
mhm,
Yeah,
mhm,
that seems like a big, like there needs to be a ton more research because those are different. Like they have
mhm.
similarities in them, but it would be really interesting to do more specific protocols for each.
Yeah, oftentimes too, I think you've probably seen that patients will come in with an IBS diagnosis and we'll do a little bit more digging and it could be SIBO being responsible for that. And that we do see actually from there was a China study um, that showed benefit with capsule FMT in the symptoms of SIBO. So that might be one that is more responsive. For SIBO, still very, very early on research, but there was some promise there of benefit.
Yeah. What do you think the mechanism would be there? Because with SIBO, it's an overgrowth of normal bacteria in the small intestine. So putting, just different microbes in from somebody else, what do you think's going on there?
Yeah, it's a good question and something that needs to be investigated further. My kind of thought process is that the overgrowth of SIBO is from quote unquote good guys, but maybe that balance is incorrect. And so even some of those good guys can overgrow without control. And if we have add in some different quote unquote good guys that help keep that balance a little bit further and prevent that overgrowth. Um, and then also too, like different immune responses that I would imagine is a big part of it are uh, the diversity of our microbiome is important for how our immune system responds. And we're learning more and more about how that matters for things like digestive symptoms, motility, etc. So I would imagine that plays a role in it as well.
Yeah, absolutely. And just the diversity is what you're getting at, right? Where it's,
Hmm.
enhancing the diversity of the gut microbiome to allow it to balance itself more.
Hmm.
That makes a lot of sense to me. And then there's always definitely at least a few times a year, I get a call about people that are interested in weight loss and they've heard that FMT may lead to weight loss, and that's why they want to do FMT. How do you answer those questions and any research behind it as well?
Yeah, so this is a tough one because weight loss is such a sensitive subject, and people often have tried a lot of things for that. There are research to support that certain bugs may be present in those who have a higher BMI or be more present in higher numbers, but we don't have any true research that FMT is beneficial for that weight loss. I typically do not recommend FMT for weight loss. It is, we'll go through the process. It takes screening and it is a significant process. So not my first go-to for that. Typically recommend against.
Yeah, yeah. It's not even like my 100th thing on the
Yeah, yeah,
list
yeah,
for weight
yeah.
loss. But there was I like the rat study. Do you remember it? I can go through it too if not.
Yeah, refresh my memory.
Yeah, so there was, I think it was a mouse study that was done. I don't know any of the specifics, but basically the real basics of it is they had an obese mouse and they took the stool from the obese mouse and they transplanted it to the lean mouse that was
Mm,
normal body weight. And the lean mouse became obese. And then they
mhm.
reversed it, and the opposite also happened where they took the stool from the lean mouse and implanted it in the obese mouse, and the obese mouse lost weight. And so this is where I think a lot of people are getting it from, where, things have been written in the media saying FMT causes weight loss. It's like this miracle thing. And, if you're
Mhm.
overweight, then it's all due to your gut microbiome. And these blanket statements have been made, but we haven't seen it in humans yet, is the big thing, which is what we need to see to actually prove any efficacy when it comes to treating obesity in human populations.
Yeah. Mhm.
Um, but interesting nonetheless that it even happened. So I think definitely more research, and it gets back to, whenever I talk to any researchers on this idea of like what is the optimal microbiome for any of these conditions. I think likely that we're going to figure out that there's something called like a super donor, where they get better results from this one person being the donor for multiple people. And what is it about that person's stool specifically that is effective in treating ulcerative colitis or Crohn's or what have it?
Mhm. Yeah, and that's definitely hopefully where we're going with research. I think we do know as far as diversity is very helpful,
Yeah,
but that's as far as like the claim that
yeah,
we can go for. Mhm.
yeah, makes sense. Okay. So let's go through general protocol in terms of if somebody is looking to get FMT for ulcerative colitis or Crohn's disease, and they're not approved for Rebiota or Voust.
Mhm.
But what would that process look like if they were to do that?
Yeah, so that first part is finding a donor and screening a donor. So typically, if you want to dive into what screening looks like, we're generally looking for a healthy person who is having a bowel movement, at least one bowel movement daily, and hopefully eating a diet that is supportive of a healthy microbiome. So it doesn't have to be anything perfect, but regularly consuming fruits and vegetables, fiber, things that would promote a healthy, diverse microbiome. Um, with that, so then with screening, we do both blood and stool screening. It is possible to transmit infection through stool, so that's why we need to do that screening. With blood, we're looking for things like HIV, viral hepatitis, um, syphilis are big ones. And then with stool testing, we're looking for A. C. diff, any common enteric pathogens or parasites. It's very possible for people to have a colonization of a pathogen, but not have any symptoms. So definitely always want to do the stool testing there. Some people will forego the blood testing if it is an intimate partner or a child, but always want to do that stool testing. Um, and then so we go through the donor screening, find an appropriate donor. Next steps would be to take the donor stool, collect the donor stool. We blend that with either saline, filtered water, in a blender that you don't plan to use again or one that you have not used prior. And then we take that, we filter out the larger particles, and we call that solution the fecal slurry. And then we take that fecal slurry and we put it into an enema bottle. And then we use that for retention enema to deliver to the colon. Typically, trying to hold on to it for about 4 to 6 hours, but that is something we can talk about if it's difficult with any of your current symptoms, et cetera. There's options there. And then, like I said above, we typically start with roughly 10 consecutive or semi consecutive treatments and then go from there, depending on how one responds. Sometimes we continue with more frequent, sometimes we start to taper it off, um, depending on how somebody responds.
Yeah, yeah, interesting. And I like the comment about how you're not going to use this blender for smoothies tomorrow. So we're keeping them totally separate.
Yes, yeah, yeah. This is a different one.
I had a patient set up like a workshop in her garage, almost like this like sterile area that was like her kind of lab that she used, which seemed to work
Mhm.
well.
Yeah.
So with FMT, when they're going through this tract, you had mentioned child briefly. can children be used as donors, and like what, because the microbiome changes hugely from the day you're born till, when you become an adult. So
Mhm.
what's the cutoff there, and how do you talk to patients about that?
Yeah, so you can use your child as a donor. At around 3 years old is when we see that microbiome becomes more like an adult microbiome as far as diversity goes. However, there is still benefit from those 0 to 3 years. So we've had patients use their newborn babies and have significant benefit. So it might not be that kind of quote unquote perfect diverse microbiome that we're looking for, but we see benefit. So definitely can use any age. The one thing with kiddos is that oftentimes, I think it's around 30% if under 2 years old, can have C. diff present in their gut. And so that's, again, even if child always want to do that stool testing,
Yeah, yeah,
because that's not something we want to transfer.
yeah, absolutely.
Mhm,
Um, and then when somebody's watching this video, they may be like, this is a no-brainer, I'm gonna do it.
mhm,
But what are the potential risks, as there are with everything with FMT?
mhm.
And have there been any like severe cases in terms of death or anything that's, scary?
Yeah. So the three things that we think about with safety for FMT is one, transfer of infection. And so we do our best to screen for that. And that um, has been generally preventative of transferring pathogens. However, we can't test for everything. There's always going to be that um, possibility that we transfer something that we can't test for, that we don't know about. There's thousands and thousands of pathogens. We can't test for every single one. Um, Historically, so FDA in I think 2019ish put out um, a kind of press release that there was two people who passed away that were immunocompromised and had received stool that had antibiotic resistant bacteria present in there. And so from there, stool banks have started screening for those antibiotic resistant bacteria strains, and that is something that we can do too. For home FMT, you can screen for those strains, and it's more important too, especially if somebody is immunocompromised because they do not have the immune system to fight off.
Yeah, yeah.
Mhm.
Yeah, you said that was 2020. I remember that turning point too, where we were doing most of our donor screening through Quest Diagnostics. And then when that came out, Quest doesn't run those resistant genes. What Dr. Scheeler is talking about is that there's certain bacteria that are resistant to things like vancomycin. And so if somebody is present with those, then they would not be an ideal donor for the person, for sure, especially an immunocompromised person, of course.
Yeah,
But there's other labs that do run them, and we're hoping Quest gets their stuff together and can actually do those eventually one day.
yeah, fingers crossed. Yeah, but so outside of infection, other one that we think about is allergens. So it is possible to pass along allergens to the recipient. So if somebody has a true allergy, true food allergy, we do recommend that the donor avoid those allergies for a week prior to donation to prevent that from happening. And then last risk would be what we call mechanical complication, which is uh, complication from the tube itself in the delivery method. So if you are doing a nasoduodenal tube, the tube that goes through the nose into the small intestine, or endoscopy, that tube itself can perforate the esophagus, stomach, small intestine. And then again, colonoscope, same thing with that. You can perforate the colon, and you can do that with enema as well. Very, very low risk for all of those things, but it is possible. So we like to make sure that patients are aware of that. With the enemas too, we talk about if it shouldn't be painful. So if you're feeling any pain, then we need to pull back a little bit and kind of investigate something that's going on to um, prevent that.
Yeah, yeah, okay. And I had a question, then I got too into listening to you, so I'm trying to remember it. But with the complications, you were saying, oh, the allergen piece. So what you're saying there is that you have a donor who has an allergy or a recipient who has an allergy.
Recipient. So if the recipient is allergic to peanuts, we would ask the donor to avoid peanut products for a week prior.
Okay, that makes sense.
Mhm.
So you're not like transmitting an allergy from one person to the other,
Oh,
but
no, no, no.
instead,
Yes, yes.
as the
Yes.
recipient, Yeah, if you're exposed to the antigen, like the peanut or something, then you could have a reaction to it potentially, right? Because there's also going to
Correct,
be
correct.
digestion that's happened. Yeah. Okay.
Yeah. Mhm.
Makes
Mhm.
sense. And then can you go over any case studies that you've had in terms of like somebody walked into your practice with either let's do maybe a Crohn's and a UC patient if you have one, or IBS, whatever you think would be a valuable thing for people to hear about in terms of what that looked like and the results.
Yeah, I can talk about, maybe one positive, one negative, so we can get
Perfect.
both sides of the spectrum. So I had a Crohn's patient, who was a male in his or he was male in his 30s, and he, um, had, moderate Crohn's disease. He had, been on, a biologic before, decided to come off on his own because he did not no longer wanted to be on the biologics for whatever reasons. And then he did the 10 treatments that we talked about, and had significant benefit in symptoms. And we saw his inflammatory markers coming down almost immediately. And so he had the kind of classic perfect response that we want to see, improvement in how he was feeling, improvement in those markers of inflammation that we were seeing. And then with time, after the 10 treatments, that held his symptom improvement, a complete resolution actually, and inflammatory markers stayed low. And then when he had endoscopy, all signs of Crohn's disease were not present. So his met both the histologic remission and the clinical remission following those 10 treatments. And now we monitor he's on about every 6 months. We'll take a look at some of those inflammation markers, he pays attention to his symptoms. If he feels a little bit like he's not 100%, he has kept some of the donor stool and he will do 1 or 2 treatments. And that is enough for him to maintain that remission. And so he responded really positively, and continues to respond positively. And I think that's been probably around 2.5 years now.
Wow.
Um, yeah, and then the other patient,
I'm going to jump in
oh,
really
sorry. Yeah,
quickly because I want
yeah.
to ask about that patient. He kept the donor stool. How long can you actually keep donor stool? You know, I'm guessing you're freezing it, but how long would you tell somebody that you can keep it before it's useless?
Yeah, so the one important thing with donor stool is that it cannot be a home freezer because we have home freezers have defrost cycles that does not support the viability of the stool. So he has a medical grade freezer that he just keeps in his basement. And then he also still knows his donor, so they will occasionally retest about every 6 months or so just to kind of maintain stock. Um, but as far as viability, I would say probably around a year is what I would do if you're keeping in a medical grade freezer.
Yeah. Okay. Really interesting. And I cut you off. So case number two that you're going to review.
Oh, yeah. So case number two, 20-year-old female with ulcerative colitis, and she has moderate UC pancolitis. So the inflammation is throughout her colon. And she used a family member as a donor, and we started with those 10 treatments. She did not have any benefit symptomatically. We retested the inflammatory markers and they were not changing. They were staying elevated. And what our next steps we had discussed were potentially changing donor. However, she was having pretty significant pain at the anus and with insertion, and so that we had to stop and we couldn't continue moving forward. She did not want to move forward with that. So unfortunately, no benefit there, despite that 10 treatment. Mhm.
Yeah. Yeah. Yeah, I've seen the same thing as well. I've even seen one patient where they got improvement from their donor the first time they did it, and then they had to redo it about 6 months to a year later and didn't get improvement with the same donor. Have you ever seen that?
Yes, yeah, I have seen that. And so switching donors is an option too. And frequency, there's things that we can
Yeah.
discuss there too.
Yeah. I'm really excited about Rebiota and Faust, mostly because I'm hoping, and I'm interested in what you think about this, but I'm hoping it's going to open the door for this to be approved for IBD in the future, just because, I mean, how medicine works is when there's money behind something, right? Then there's more
Hmm.
lobbying power, like there's more an effort to actually get it approved for multiple conditions because those companies would obviously make a lot more money. Um,
Hmm.
but it would also open expansion just in terms of people being able to get this that really, really need it and not have to go
Hmm.
through these measures. What do you think about
Yeah. Yeah, no, I completely agree. I think anything that increases access to FMT is generally a positive thing. And there are, I don't recall the actual names of the companies that are doing it, but there are research studies that are currently in progress for on FMT products for IBD. And so hopefully that comes out pretty relatively quickly. So that's definitely in the pipeline, something that will be in our future. It's a matter of time.
which would be huge. Like we don't want to have to go through this with our patients. We're just doing it because we want
Hmm.
to make sure if they're going to do it on their own, they're going to do it safely. But
Hmm.
how great would it be that we were just write an order for Rebiota and somebody picks it up and then they administer or we administer in office, and that's
Yeah.
the extent to which we need to do this. I also feel like we'd be able to get so much more data points, right at that point.
Mhm, mhm,
But we are using Rebiota and Voust at Modern Med for C. diff, recurrent C. diff infections, like Dr. Scheeler said. And it's just really nice to have that option now and not having to like find a donor stool bank, even with FMT, just to have something that's more accessible, more scalable as well across
mhm.
the country.
Yeah, and I think too, right now, we recently discussed as far as coverage goes, that you were able to get coverage for that, and so that's a large part too of these things getting approved, is that just hoping that that coverage maintains and that it becomes cost accessible to patients.
Yeah. Yeah, the last patient that we just got for Voust is thinking that they're going to pay between $0 and $65. What's interesting about Voust is it's 12 capsules. So you get, what is that? I think it's 4 capsules over
Or
3 days,
mhm,
which is much lower than what we've seen in the past, when we were doing, I think, C. diff, we were doing like 30 capsules or something, right?
mhm.
What are your thoughts on
Yeah,
that?
mhm. Yeah, with C. diff, I for, like, stool bankers typically doing 30 to 35 one day and then occasionally doing a second day of that depending. And that's just to be thorough, we have everything ready. I think that's great. I mean, that's the most accessible. Patient, tend to have mixed opinions about taking capsule, FMT. For some, that oral capsules, they'd rather just take a few capsules and drink it down and have benefit. Others would prefer not to orally take FMT and think that the enema is more palatable because obviously with FMT there is a little bit of that ick factor. But oftentimes when somebody starts the treatment or does a treatment, they are it's not as gross as they had anticipated to be and a lot more manageable and are open to it again down the road, should they need it, require it.
Yeah. This is also why we don't recommend it for like IBS right away. We don't recommend it at all for weight loss, but like there's so many things here and there is potential risk for it as well.
Mhm. Yeah.
Um,
I
yeah,
do see though with oral capsules is that sometimes the side effects of the abdominal distension, gas, bloating can be a little bit more significant or more prevalent for those with oral capsules. However, it's usually self-limiting, no big deal, mild compared to what um, symptoms they're experiencing from either the IBD or C. diff. But with that oral capsule, we do see a little bit higher
yeah,
frequency of side effects.
yeah. Okay, really interesting. Um, there's a few questions that came in because I asked people earlier, and so I wanted to ask you those from some of our followers on Instagram. Um, do you recommend antibiotic use prior to Oh no, I think the question is using antibiotics prior to FMT. So I think we're talking about in a donor here. So one of the things that, Dr. Scheeler would do is have a consult with the donor and go through and ask them all these questions. And if somebody has been on an antibiotic, are they a potential donor for somebody?
Yeah, we like to wait at least 6 months from the donor receiving antibiotics. Different story for the recipient, but for the donor, want to wait at least 6 months in a perfect world has had infrequent antibiotic use. Again, just because we want that diverse microbiome that antibiotics can sometimes affect.
Yeah, absolutely. I do think there was another question though about using an antibiotic prior to FMT use, which I think is directly for the recipient. So somebody comes
Yeah.
in with IBD, should they use an antibiotic before they get the donor stool just to like wipe out their microbiome for better results? Or
Mhm.
what are your thoughts on that?
Yeah, and so this is something that I do kind of on an individual basis. There
Mhm.
is research to support some of those studies did use antibiotics prior to FMT, and can be really effective. I tend just again because of the whole process, it's usually not my first step unless somebody, for IBD specifically, unless somebody has been on an antibiotic recently and had significant improvement from those uh, improvement in GI symptoms from being on an antibiotic, and then sometimes we'll think about it. More commonly, we'll use it in somebody when it is that IBS functional disorder and they've had benefit before, um, just to try to do everything we can to see benefit there. But an option, not necessarily required. It really depends on the person.
Yeah. Okay. With Valstin Rebiota, you do use an antibiotic before them for C. diff. That's like required
Right.
for prescribing, but that totally
Mhm.
makes sense. Um, any other things that we haven't talked about that you think are so important or interesting that you want to talk about at this point?
Yeah, I mean, I think I would just say I love FMT. I think it's a really, really great therapy. There is that X factor, and sometimes it can be difficult to find a donor. But that's also something that we can discuss too. I do have resources for people to share with people they know to explain kind of asking somebody to use their poop as medicine is not the easiest question to do. So I have some resources that can make that easier and kind of shed some light onto a potential donor who might not be familiar with this at all. So there is options if you are kind of sitting there and being like, whose stool would I use? We can talk through that. I think FMT can be super, super effective and definitely worth considering.
Yeah. Would you ever just use FMT with somebody that comes in with Crohn disease or colitis? Or is this usually
Tip-
part of a larger treatment?
Yeah,
Yeah.
Yeah, typically not what I use alone. There's some people who come specifically to me and they just want me to walk through what that looks like, which is totally fine. But we have a lot of tools, and I think we mentioned some of those in our previous video that we can use for inflammatory bowel disease. So I like to use what we can to get somebody into remission or improvement in their symptoms. Um, I think it does, if we start multiple things at one time, it can muddy the waters a little bit. So that's something we consider. Do we want to do a little bit of FMT first and then see where we are? Really dependent on the person. Where are we? Do we need to get things down ASAP? Sometimes in that case, we'll start with herbs that can be really potent and fast acting and then bring in FMT. It's really dependent, but generally like to use the tools that we have.
Yeah, yeah, totally agree. And just listening to this video, I think like the biggest take home is don't do this on your own. Don't put yourself at risk because you don't have to. Definitely make sure you screen your donor if you're going to go about this. Make sure also that the condition you're looking to treat has some research for FMT because there's so
Mhm.
many other treatments available for many, many issues, and to use something that's research based is um, definitely important.
Yeah, absolutely.
Thank you so much for taking the time, Dr. Scheeler. If you're listening to this and you have IBD or you want to have a consult with Dr. Scheeler, you can actually go to the link in our bio if this is Instagram, or you can go to our website, which you'll see below. Schedule a complimentary 15-minute phone call with Dr. Scheeler, see what it'd be like working with her one on one. She has her license in California, Arizona, and Maryland. So with any of those states, she has a full scope of practice. So please reach out if you want to work with her one-on-one. And we'll be posting more videos about all things gut health coming up. And let us know if you have questions.